Our first panelist this morning is Dr. Leigh Senderowicz. The title of her talk is "I Was Obliged to Accept: A Qualitative Exploration of Contraceptive Coercion." So Dr. Senderowicz is a public health expert and social demographer focusing on global sexual and reproductive health and rights. Her mixed methods research focuses on reproductive autonomy, exploring the new ways in measurement and evaluation to promote person-centered care, health equity, and reproductive freedom. She's currently an NICHD postdoctoral fellow in the Health Disparities Research Scholars Program at UW-Madison. She holds a PsyD from Harvard and an MPH from Hopkins. We're next going to hear from Dr. Cynthie Wautlet, whose title is Title 10 Reproductive Health Family Planning in Wisconsin, Challenges and Opportunities. And as many of you know, Dr. Wautlet is an associate professor in the ASOG division and is a member of both the Pop Health division and Family Planning division. She completed medical school at Johns Hopkins, residency here at UW-Madison, and an MPH here at UW-Madison. She holds the Jean Bissell Endowed Professorship in Reproductive Justice and is the Title 10 Medical Director for the Wisconsin Department of Health Services Reproductive Health Family Planning Program in the Division of Public Health. And finally, we're going to hear from Dr. Jenny Higgins, PhD, MPH, about the intimate link, contraception, pleasure, and sexual well-being. She's a professor of gender and women's studies and OBGYN. She moved to Madison in 2011 and has loved her time as a pet badger. Trained in both gender studies and public health, she conducts mixed methods research on abortion, contraception, and other aspects of reproductive health. She serves on the editorial board of Perspectives on Sexual and Reproductive Health and the Journal of Sex Research, and was a member of the board of directors of the Guttmacher Institute from 2011 to 2018. An award-winning teacher, she also teaches what we think is the largest women, gender, and health class in the country, GWS 103. So without further ado, I'm going to welcome Dr. Senderowicz for her talk, and I'm looking forward to a lively conversation following these outstanding presentations this morning. Thank you so much, Dr. Senderowicz. Okay. Go ahead with Cynthie first. Okay, Dr. Wautlet, would you be willing to give your talk first so that Leigh can have some time to get her audio working?
Sure, no problem. Can you hear me?
We can.
Okay, let me just share my screen here. Good morning. Thank you so much for including me. As Heidi mentioned, I hold the Jeannie Bissell Professorship in Reproductive Justice, which is a huge honor and also has been a huge learning curve. And my pronouns are she, her. And I'd like to just first briefly acknowledge some developments that some in this audience might not be aware of, but I think would be of interest to most people and potentially spark some ideas for collaboration. And then I'd like to briefly discuss the Title 10 Family Planning Program in the state, which is administered by DHS. So some may not know that the department recently launched a family planning section, which includes two of today's speakers. Both myself and Jenny Higgins are members, and it also includes Dr. Bennett, Jocks, Hoppy, Sharp, McDonald, and Hartenbach. And we meet regularly and have access to all the research support and the infrastructure of the department and also the ASOG division. And the division is actively recruiting for a fellowship-trained family planning specialist, which would be housed in the ASOG division. So I just wanted to share the link to the UW job site showing that posting. Please do share it in your networks. We would love to recruit somebody awesome. Anyone who has research interests or ideas to improve clinical care or services or community outreach, please do reach out to any member of the division. And we'd be happy to include you in a meeting or add a topic for discussion to an upcoming agenda. And just a couple of examples of some of the faculty's recent work. For instance, Dr. Bennett recently spearheaded an initiative which now includes mifepristone in both the Meriter Hospital and UW pharmacy formularies. And this, as you may know, is a very highly regulated medication. So that was a huge pull on her part. And so thank you to Dr. Bennett. And this will really improve care for women who choose medical management for early pregnancy loss. Dr. Jocks also recently published in the Journal of Contraception a retrospective cohort study which compared outcomes of patients who underwent both D&E and also medical management with mifepristone and misoprostol for second trimester elective termination of pregnancy. And so if you haven't read that article, please do. It's generated a lot of really interesting discussion. So I just wanted to highlight that. For those of us who are attending the department meeting, which follows this Badger Bytes talk, Amy Williamson will talk more about this, but I also did want to give a shout out to the Wisconsin Contraceptive Access Network. This is lovingly referred to as We Can. So if you hear about We Can, this is it. So this was initially spearheaded by Drs. Ehrenthal and Rice, and it's now led by a diverse statewide steering committee and administratively by Amy Williamson. So the vision you can see here, which is to create systems and policy change that will ensure full access to safe and effective contraceptives across the state without coercion. And the website has great online resources. Also, the We Can News Digest comes out regularly, and it provides really great updates about contraceptive care, especially in the recent wake of COVID and with ongoing Supreme Court challenges. So if you haven't signed up to receive the newsletter, I would highly recommend that. I'm a member of the healthcare work group, so if you have an interest in joining the network, please do so. Reach out to myself or Amy Williamson. And then personally, I'd like to mention just a couple of things. I've been working on several trainee projects using a retrospective data set from the Ryan Lark program, which provided post-placental IUDs and immediate postpartum Nexplanons to postpartum patients at Meritor's Birthing Center. Most recently, I'm working with Caitlin Landry, who's one of our medical students, to look more deeply at those IUDs that were removed or expulsed. We have follow-up data for 6 months on all patients, but we're extending that follow-up period. So she's doing a summer Shapiro Research Scholarship program, and if you have an opportunity to attend, please listen for that presentation in the autumn. We recently also gave grand rounds on the institution-wide faculty abortion survey that was conducted here at UW, so I won't get into any details about that. But if you have interest in following up or doing secondary analysis of some of the data, feel free to reach out to myself or Jenny Higgins or Nicholas Schmuel. We have 2 papers that are currently under review and a third, which I am painstakingly slowly drafting, but hopefully that will be submitted in the near future. And then the last thing I wanted to mention personally is that I've recently joined the state's maternal mortality review team as the interim co-chair. And we're taking a really deep dive into the medical records of each and every woman that died in pregnancy in the state of Wisconsin. And one part of that assessment is to see if we can identify whether the pregnancy was unplanned or whether a lack of access to family planning services was a contributing factor, and then make recommendations statewide for action that would include expanding and ensuring access to acceptable and affordable contraceptives for people across the state as a specific means to reduce preventable maternal deaths. So I found that to be somewhat surprising that that was something the maternal mortality review team was doing, but I wanted to make sure people were aware. I think it's a really exciting addition to their analysis. And then I'd like to spend just the last couple minutes talking about the state's Title X program. So as some of you may not be aware, in October of last year, I took on the role of being the medical director for the state's DHS's Title X program. And my hours with that program, as you can imagine, are limited and pretty variable because of my other clinical and other commitments to the department. And the learning curve has been really steep and kind of slow, but also interrupted very much by COVID, as you can imagine. So most members of the DHS family planning team, including our epidemiologist and our nurse consultants, had many of their hours redirected to COVID response, including contact tracing. But there is movement with Title X at the state level, and I wanted to share just a few highlights. So first, as most of you know, Title X is a federally funded program. It was part of the Federal Public Health Services Act, which was enacted actually under Richard Nixon in 1970. And the aim broadly is to provide contraception, STI screening, and other reproductive and preventive health services with a focus on reaching low-income people. The program requirements are developed at the federal level, by the Office of Population Affairs so that the program and eligible grantees can administer a program that meets the federal requirements. And the Federal Secretary of Health and Human Services has the final authority to award the funding. And both nationally and in the state of Wisconsin, Planned Parenthood had been a longstanding recipient of the Title X funds. We don't have a whole several days to talk about what ensued, but basically in 2016 in Wisconsin, the legislature required that DHS compete with Planned Parenthood for that federal funding. And 3 years later, in March of 2019, DHS was actually awarded the grant and Planned Parenthood was no longer a federal grantee in the state of Wisconsin. And then following that, last summer, the Trump administration implemented what is now widely known as the new rule, which expands on previous Title X restrictions and federally prohibits the use of any Title X funds to perform, promote, refer for, or support abortion as a method of family planning. The new rules also no longer require non-directive pregnancy options counseling and requires not only financial separation of Title X from non-Title X services, which had been there previously, but also requires physical separation of Title X from non-Title X services. It also expands the reporting requirements by the grantees, and it requires that any informal partnerships or referral agencies with which Title X recipients associate be reported. So since those restrictions in August of last year, federally, Planned Parenthood withdrew from Title X because of all of those restrictions. And at that time, some states with laws that are more prohibitive and less restrictive than the federal guidelines actually chose to no longer receive Title X funds and to self-administer their reproductive health programs. And this was before I had joined DHS in the state of Wisconsin, but my understanding is that the state of Wisconsin underwent a similar review. And in fact, in the state of Wisconsin, it was determined that our state statutes and laws are just as restrictive, and in some cases, actually more restrictive than the federal regulations. And so they opted to continue with the Title X funding statewide, given the reproductive health needs of the people in the state. So as you can imagine, there are lots and lots and lots of challenges that Title X is facing as it tries to adapt to many things that are happening. So first of all, there's, of course, COVID. And so we had to redirect a lot of time to creating websites. One is patient-facing and the other is provider-facing in order to reaffirm that reproductive health and family planning services are essential services, even in the time of COVID. And to create tools for clinics statewide to be able to pivot to doing telehealth. And yet many county and local Title X service agencies were forced to either close temporarily or severely limit their hours, or they were significantly delayed in adopting any telemedicine capability because it was something that most of them had never done before. The other challenges that we're facing is that DHS recently underwent a reorganization. They added a new unit, and so we're recruiting for a reproductive health unit supervisor. That's a position that had to be reposted. And so as you can imagine, when reorganization is happening and there are several leadership vacancies, this adds challenges to getting programs and projects going and approvals that are needed going. And then each state also has to undergo a legal review, an independent state-by-state legal review of the new federal requirements, which is the 2019 new rule. And the compliance document, which was generated primarily by our prior former section chief, had to go through a lot of legal channels in the state in order to be reviewed, and then was up for a mandatory waiting period for public comment. And so that also delayed things by quite a bit. And it actually has yet to be formally approved and disseminated statewide to our stakeholders. So compliance with the new rules is remaining a huge challenge. There's also a lot of service variations across the state. The way the program is currently administered, funding is routed to county and local health departments and subrecipients. And because of local program administration and local autonomy with administration of the program, there's still quite a bit of service variation across sites. There's a lot of variation in the medical records that people are using. Some are electronic, some are still paper. There's several different versions of electronic medical record keeping. And as you can imagine, that makes documentation and reporting requirements a challenge. And then there's also quite a bit of variation in the engagement of local medical directors around the state that are collaborating with the local and county health departments and the other subrecipients to administer the services. And then especially in the light of COVID, it's very challenging for sites to keep up with the reporting requirements, including 6-month reviews and annual reviews of the program. But all of that said, I think there's a lot of opportunities for DHS, but also for our department to engage and really try to see what we can accomplish in light of these challenges in terms of bringing better contraceptive and reproductive health services to people statewide, especially with the focus on reaching low income and marginalized and otherwise underserved peoples. And so one thing that we did early on after I joined in 2019 was to change the name of the program from Women's Health Family Planning, WHFP, to Reproductive Health Family Planning, RHFP, as a way to show more inclusivity in engaging with all people in the state who need these services. We're also updating all of the program guidelines, and that's been a huge challenge. We hired a new APNP at the state level, and she and I sent out urgent updates to update some of the things that were really outdated, but we're doing a very broad update to all of the state program guidelines. And as those are disseminated, hopefully by October, November, we can start to do even more work with improving the quality and the scope of services that different clinics are able to provide. Many of the nurses at different sites are operating under these program guidelines with delegation protocols, and we need to solidify those practices, especially in collaboration with the local medical directors. And we're also working actively to expand services so that more people can be reached and the scope of services can be broader. So there are new care models that have been introduced, including a couple of multi-county consortia, and those either individual counties or multi-county consortia have hired new APNPs. Like I mentioned, we hired one APNP that works directly at the state level, and I collaborate with her closely. But there's other APNPs that have been hired in different areas across the state, and we're hoping that's a model that will continue to expand. And many of those APNPs still need to either be trained or be updated in their ability to provide LARC and other services. So I think there's a huge opportunity to improve the scope of the services. And then also, with the program guidelines and the new staff, I think there's a huge opportunity to improve the scope and quality of services, especially with the health department looking at enhancing training and technical assistance at the state level. And I think our department could really be engaged in some of that work, especially with training new APNPs to make sure that they're skilled in providing comprehensive counseling, avoiding reproductive coercion, and providing LARCs when necessary. And the last thing I'll mention is that the Wisconsin Reproductive Health Conference, which is sponsored by Title X, Wisconsin DHS, and WIFRA, is happening via a virtual platform. That'll be August 26th and 27th. And then I've provided the registration link. So if you want to sign up and attend any sessions, please do. There's a focus on health equity, access for LGBTQ+ people, and especially youth and adolescents, and then also sessions on postpartum and perimenopausal services. So please log in. Thank you.
Thank you very much, Dr. Wautlet. Dr. Senderowicz, did you get your audio working?
There we go. Can everyone hear me now? Okay, great. I'm so sorry about that. Of course, I tested my audio last night and this morning, and it worked great. And then today, when it's showtime, that's how it goes. So let's see. Now, can everybody see my screen, I hope?
Yes, we can.
Okay, great. Thank you so much. Thanks for the response. I'm so glad to be here this morning with you all. I'm going to talk a little bit about my work on contraceptive coercion, which I know can be a little bit of a hot topic. So I'm really grateful for the invitation to come speak with you today, and I'm looking forward to this conversation. So let's dive in by thinking about the question, why should we care about family planning? And that might seem like a little bit of an odd question to ask a group full of OB-GYNs. I'm sure you all have many, many reasons why you think we should care about family planning. But let's think through just a few of those reasons. So in the global discourse on family planning, there are a myriad of different rationales that are offered for promoting and expanding family planning services. Among those are a feminist rationale to promote contraception as a matter of bodily autonomy, an environmental rationale to alleviate climate change, an economic rationale to reduce poverty, and a public health rationale, of course, to promote both maternal and child health. So we have lots of reasons that we want to support family planning. And this screenshot from a family planning advocacy website shows how some of these arguments are deployed at once, framing family planning as, quote, the smartest investment that we can make, capable of improving outcomes in everything from HIV and malaria to education and sanitation. But of course, we need to remember that despite all of these purported benefits, family planning has not been an emancipatory project for all people since its inception. Rather, family planning has been tied in with a range of efforts to control not only fertility overall, but also to decide which bodies were targeted for fertility reduction. In the United States, the Eugenics Movement targeted the bodies of racial and ethnic minorities, disabled people, people living in poverty, and others for compulsory sterilization and other efforts aimed at limiting their reproduction. In the international context, after World War II, neo-Malthusian concerns about global overpopulation became part of the nascent development project. Concerns about global overpopulation were so strong in this era that many scholars and policymakers defended the use of coercion as a legitimate means to ensure limits on reproduction. So as an example of this, here we have in 1979, Bernard Berelson, who was the president of the Population Council, promoting what he called a stepladder approach to coercion, writing that, quote, there are undoubtedly cases of justified coercion, but cautioning that overt violence or other potentially injurious coercion is not to be used before non-injurious coercion has been exhausted. Many countries throughout the global South adopted population policies such as economic penalties for high fertility, quotas for providers, and compulsory sterilization for women. Of course, today, most programs vociferously disavow this type of overt coercion and assert the importance of voluntarism in all of their programs. But despite this, there's still a really big emphasis on fertility reduction and contraceptive uptake in many programs today, with maximizing contraceptive uptake still the ultimate goal of many global family planning programs. So that led to the question guiding this study I'm presenting here today, which is what happens to people's experiences if or when fertility and or contraceptive uptake goals drive family planning programs. And I set about to answer this question by talking to women about their experiences, and I won't spend too much time here on the study methods, but I'm really happy to go into more detail if folks have any questions. So the results I'm going to present come from a larger sequential mixed method study that was designed and carried out in an anonymized country in sub-Saharan Africa. The country context is characterized by a post-colonial status, weak health system, and a heavy dependence on foreign aid. For the paper I'm presenting here, I'm using data from 49 in-depth interviews with women of reproductive age and key informants from the health system. We used a purposive sampling strategy for diversity across age, education, marital status, and religion. We also used an open coding approach with inductive content analysis, assigning pseudonyms to all respondents. So I'll dive right in here to some of the results. And you'll have to forgive me, I always find that this type of qualitative study is really uniquely ill-suited to PowerPoint presentations, so I hope you'll all bear with me through some really big blocks of text as I try to summarize some of the interesting results. So since I only have a few minutes, I'm going to zero in to, I think, one of the key results of this study, which is that coercion is not a binary outcome, it's a spectrum. So rather than thinking in black and white terms, it might be helpful to conceptualize coercion as an array of practices intended to increase contraceptive uptake, ranging from the subtle to the overt. So what do I mean by that? I want to start with an example of what I'm calling subtle coercion, and we'll start with Maria, whom we asked to tell us about her contraceptive counseling. Maria replies, well, the health workers normally counsel you that if you want to choose, you have to choose the 5 years, by which she means the implant. Now, if that method isn't suitable for you, you can take it out and get to 3 months, the injectable. But if you don't like that, you can't take it out. You have to wait for the 3 months to be over, otherwise you can't remove it. So it's the providers who told you. It's true that there's counseling and they tell you to choose what you like, but where they think it's best, it's only the 5 years, the implant. So I've called this type of bias and directive counseling subtle coercion. There's no use of threats or violence, and yet it's clear that Maria is describing a situation that constrains her autonomy and her decision-making. Here's another example of subtle coercion. Our interviewer asks, how did you get to the decision to use the injectable? Carol replies, because the health worker said that if you give birth via C-section, you must use the injectable and wait 5 or 4 years before your next child. If the health workers hadn't told you to use this contraception, would you use it? No, I don't like the injectable. So of course, to this audience in particular, I don't have to tell you that there's no credible evidence, obviously, for requiring a birth spacing interval of 4 to 5 years after a C-section, nor any medical reason after a C-section to mandate the use of the injectable, and yet the provider was sharing this false medical information with Carol to try to get Carol to use the provider's preferred method of the injectable. Here's an example of what I'm calling moderate coercion. Cynthie tells us about her 45th day checkup, which is the last of the routine postpartum checkups in this country that women are expected to attend. And Cynthie tells us, when I brought my child into the world, I went back for the 45th day checkup, and the nurses asked to see if I was going to use a contraceptive method to save my birth, and I said no. They told me that if I decided not to use family planning and then later I have problems and start to run panicked in the midday sun to say that people should help me, it would be complicated. They would refuse. When they spoke like that, in all honesty, it made me scared. So in this case, the provider is threatening to deny Cynthie future medical care for any pregnancies that might result if she does not adopt the postpartum contraceptive method. And so with moderate coercion, we've graduated now to things like threats and scare tactics. And here's an example of what I'm calling overt coercion. Jessica says, when I got pregnant with my 10th child, the midwife told me that I have a lot of children and that I would have a difficult delivery. The health workers in a nearby town said that I needed to get the implant by force. I was obligated to accept, and they gave me the implant. The nurse told me that it would be 5 years, and even before the date of the 5th year, I started to feel illness due to the implant. I went to tell the hospital that I got headaches from the implant, and it's there that the health worker told me that the date to remove it hasn't yet arrived, so he can't remove it. He refused. He said that it hasn't yet been 5 years, and there are 2 months that still remain. So there's obviously a lot going on here, but I'll just focus in on a few key things. Jessica was forced to get an implant due to a provider's perception of high parity. It does not seem that she was given any choice of the method that she was provided. Then, instead of viewing the 5-year duration of the implant as sort of a maximum period of efficacy, many women told us stories of providers treating that 5-year period as the minimum duration of use, refusing to take out implants before that time had completely elapsed. In this case, the provider is forcing Jessica to keep a method that she clearly wants to discontinue. And provider refusal to remove LARCs was one of the most frequent types of contraceptive coercion that women reported in this sample. So here again, I'm showing this whole spectrum so you can see how I've mapped out these experiences. Things like biased counseling, extremely limited method mix, and the provision of false medical information are mapped as subtle coercion. Threats to deny future care, scare tactics, or insisting until the person accepts are mapped as moderate coercion, and inserting methods without consent or refusing to remove LARC are mapped onto the more overt end. So just to sum up, the key takeaway here is that coercion doesn't necessarily need to involve overt force or violence. Threats, misinformation, and even biased counseling can constrain free choice and limit contraceptive autonomy. It's important to note that coercion doesn't just happen at the time of method provision, but with LARC can sort of be on this protracted timeline if discontinuation can't be had when the woman desires. And the takeaway, I hope, is that family planning programs, both globally and here in the U.S., should be really fundamentally reconceptualized to prioritize person-centered and rights-based care rather than promoting contraceptive uptake. And I'll just take a quick minute to thank my funder, the Packard Foundation, and thank you all very much for your time. Thanks.
Thank you very much, Dr. Senderowicz. Dr. Higgins, would you be able to give your presentation now?
Yeah. All right. Heidi, could you confirm? Okay, great.
We can hear you and see your slides.
Excellent. Thanks. It's nice to see you all and really nice to share the stage with Cynthie and Leigh. I'm going to be talking about sex for the next few minutes here. And what better place than to start with a Cialis ad image here. So for those on the phone, I'm sorry you won't be able to see these next few images. So I start with an image from a Cialis ad, which of course is eroticized, because it sets up a nice juxtaposition for the complete lack of sexiness or eroticization with contraceptive advertisements, right? So we use sex to sell just about everything in our culture except contraception. So here are just a few of some of my favorites. Here's just a, just a straight up Implanon ad that makes it look like any other, medical good that has nothing to do with sex. Here's a seasonal advertisement, a woman by herself. This Skyla campaign is one of my favorites. Here's somebody pushing a camera in a swing. And then this incredibly sexy image of a woman folding laundry with her toddler for a Marina ad. So what you might see here, or what you might not see here, is anybody getting it on, right? So I just think, I know you all know this, but we tend to, well, forgive me for a moment. I think these ads tend to show us how we see contraception, or how we approach contraception both culturally and clinically as a medical good, However, contraception is inherently a sexual good. It is used primarily for sexual contexts. And I know you all know this, but people don't have sex to use contraception, right? They use contraception so they can have sex and the pleasures of sex and the intimacies of sex without having babies they don't want, right? But we tend to treat contraception as a medical good. And there's some real gender dynamics of this, and there's some real consequences of this. One just other example that we see of this that continues to just amaze me over the years is that very few contraceptives are tested for their effects on sexuality. The exceptions on this, gang, are methods that are developed for male bodies, right? So any trials of hormone-based methods for male bodies inherently ask questions around, will this affect erectile function, orgasm, pleasure, other aspects of sexual functioning and well-being? Those same questions are not asked of methods that are researched and developed for female bodies. And at a clinical level, we don't make many efforts to match patients with methods that maximize sexual enjoyment or minimize sexual discomfort. And I got interested in this topic as a patient assistant and a counselor, working with patients who talked about their sex lives, but I had very few tools to help guide them to methods that might work better with their sex lives than others. So this gap between how we sort of approach contraception from a clinical and public health perspective and the actual sexual contexts in which contraceptives are used, this is a gap I've called the pleasure deficit in my research. And essentially, I've spent my career trying to address this pleasure deficit. And I could talk all day about all of this work. I'm going to very, very briefly just say I've done this in a few different ways. First, I think it's been through theory and concept building, right? So naming the pleasure deficit, trying to develop a concept of this back 15, 20 years ago, further developing that into this notion of contraceptive sex acceptability or sexual acceptability of contraception. I've also, with colleagues, conducted a good deal of qualitative research that helps identify some of the domains of the sexual acceptability of contraceptives, including a study of IUD and implant use with Eliza Bennett and other team members here at Wisconsin. I've done some cross-sectional secondary data analyses, both with nationally representative data of condoms and pleasure, as well as some smaller secondary data analysis data sets. And more recently, I've worked with some teams to look at this at a clinical level. So among patients starting new methods of contraception, what happens to their sexual outcomes and how can we track those, including this recent paper in the Green Journal. And I think taken together, this evidence base really suggests that pleasure matters to people. And it gets at some of the domains of how pleasure matters and has shown that, hey, there may be something here. But until now, I haven't had the opportunity to do this big, fabulous, huge longitudinal clinical study. And now I'm in the middle of that. And so for my remaining few minutes, I just want to tell you about this study that I'm about 3 years into. We have one baseline paper published, but the others are not out yet. So these are very preliminary findings. I appreciate the chance to give you a couple tidbits. This study is funded by an NIH R01, as well as a number of different grants from foundations. And I collaborate with the wonderful folks at the Family Planning Division at the University of Utah. Dave Turok is the division leader there who gave grand rounds at our departments a number of years ago. So her Salt Lake, let me talk about what this primary question that we're asking with this particular study is, to what extent can sexual acceptability help explain, that and as a typo, help explain contraceptive selection, satisfaction, and continuation. And sexual acceptability is this really broad concept that refers to how contraceptives affect functioning, pleasure, satisfaction, and well-being. And gang, it's really complex. So we have many, many, many measures. Part of the point of the study is to see which measures are the most sticky and perhaps the most important and the most clinically relevant. So this is a large prospective cohort study of people seeking contraception in Salt Lake County, Utah, which is much more diverse than you might think when you hear Utah. Patients select the method of their choice and can switch for free at any time during their enrollment in the project. It's not unlike the Choice Project, but with some different goals and this very large sexual component of the study. Eligible patients who enroll provide data at baseline, 1, 3, and 6 months, and then every 6 months for up to 3 years. We have this fabulous retention rate at 6 months. We have just these tremendous study coordinators, as well as a lot of interest in the study among the patients who were involved, and an incredibly robust sample size. We wildly exceeded our goals for sample size. So we have over 3,500 patients in our sample. So in terms of method enrollment, when all cost barriers are removed, we see a lot of folks have chosen levonorgestrel IUDs and implants, but also pills, copper IUDs, depot, and rings, and then a few folks choosing patches and other methods, but those make up less than 1% of the overall sample. And so I want to highlight 3 little finding tidbits for you, gang. And just asking again for your patience as we're still working through these findings conceptually. So the first highlight is that sexual functioning and satisfaction may not change over the course of the study, but many patients perceive that their contraception is affecting their sex life. And about twice as many folks report positive versus negative sexual impacts. So this is good. So I'm going to walk you through a couple illustrations of this. So I'm going to show you a graph here of average female sexual function index scores. The FSFI measures things like orgasm, lubrication, arousal. It's an incredibly widely used measure of function. And the different color bars you see here, the different method groups. You see this beautiful flat line. This is a big fat nothing burger, right? So we're not seeing any change in sexual functioning over time when people initiate one of these new methods. We see the very same thing with a scale called the new scale of sexual satisfaction. So we see nice flat lines with this new sexual satisfaction scale. Where we seem to be getting the most money, which measure seems to be really coming forward, is a measure where we just ask people, do you think your method has affected your sex life in the last month? And if so, do you think it's had a positive effect or a negative effect? I'm going to show you 3 busy slides here, but I'm going to walk you through them. So if you can see on the bottom here, the bottom of the screen, these are the categories of responses to, has your method had an effect on your sex life in the last month? The black bars are the total sample, the different colored bars are different method groups. You see that about 40%, 41% in that does not affect my sex life at all or hasn't affected my sex life at all. On the right side of your screen are people who say their method has improved their sex life in the last month, and about 50% say that at 1 month, and a minority say that it's made their sex life worse at 1 month. And I'm going to show you what happens at 3 months. That neutral category goes up. The percent reporting both positive changes and negative changes goes down slightly, and similarly at 6 months. So we still at any one point see more positive effects than negatives, but by 6 months, the majority in this neutral category, which is certainly much better than no change. In multivariate analyses, we've been looking at, okay, what helps predict what makes someone say that their method had a positive versus a negative effect on their sex life? And this is not surprising. Perceived sexual improvements were associated with decreased vaginal bleeding, and perceived sexual detractions were associated with greater number of reported physical side effects, such as bloating and headaches. And this makes a lot of sense to me, gang. Like, less bleeding can have an impact on your sex life. Feeling less crappy can have an effect on your sex life, right? So it's nice to sort of be showing empirically something that makes a lot of sense intuitively. So the second highlight, and the next 2 highlights are very brief. I'm just going to show 1 slide each. That this perception question about impact is strongly, strongly correlated with method satisfaction. And I'll just pause here to say that upwards of half of new start contraceptive users, gang, will stop using their method within a year. Let me say that again. Upwards of half of new start contraceptive users in our general population will stop using their new method within a year, meaning dissatisfaction is really high, right? So we're interested in what helps predict satisfaction and continuation. So let's look here. On the bottom axis, these are people who say they're either completely dissatisfied with their method, going up to completely satisfied. And these are pooled observations. That's why we have these nice big N's. The different colors represent people who say that they're the impact that their method has had on their sex life. So those red bars are people who said, my method has had a negative impact on my sex life. So and the yellow are people who said that it's had a positive impact. So if you look at the completely satisfied group, there are only 4% of people who said their method has had a negative effect on their sex life. Among the completely dissatisfied, it's 54%. We see this beautiful stepwise trend here. So it's not rocket science, gang, but it's just really helpful to be able to show empirically what we know intuitively. And finally, and this is something that we're just working on this week, and just working with the data output. So it's super fresh. So I just have a text slide here. But that patients' perceptions of how their method affects their sex life, not shockingly then, is a major driver of contraceptive continuation and discontinuation. And I almost put the major driver here because it trumps all other covariates in our model. And so this is just sort of this text summary of our models. So reported sexual impacts of one's method within the first month of use was more strongly predictive of discontinuation or continuation at 6 months than bleeding changes or physical side effects or mood-related side effects, as well as pretty much all other covariates in our model, meaning that while side effects matter, bleeding changes matter, this notion of how patients perceive their contraceptive methods sexually seems to be hugely important and something we really need to attend to. So I want to remind you all that contraception isn't just a medical good, it's a sexual good that allows people to engage in sex without having babies they don't want. I know you all know this, but I think we forget about this in our day-to-day lives as public health and clinical experts. what we are really finding is that reported impact, what someone thinks about how their method is affecting their sex life may be one of the strongest predictors of both method satisfaction and continuation. And I think what's exciting for me is that a lot of people are saying their method improves their sex life. And so how do we think about working to actually promote sex-enhancing aspects of contraceptive methods, as well as how to best match folks with methods they'll find sexually acceptable? Imagine if some of you were with your oncology patients, had a chemotherapy or had a drug that like 50% of people said, this drug makes my sex life better. You'd be telling them all about it, right? And so we have this medical good that 95% of people of reproductive age will use, and a lot of them are saying it makes their sex lives better. And I think we should be promoting that, not unlike this bedsitter piece I wrote a few years ago based on another of our studies. Like, how can we actually think about using these messages to not only promote contraceptive use, but promote overall better sexual well-being? And I'll stop. Thank you so much.
Well, I want to take a moment to thank all three of our presenters this morning. What really remarkable and interesting work happening across the department. I'll open it up first if anybody has a question. And if not, I will ask a question. Oh, I see Dr. Wright. She's raising her hand. Dr. Wright,
Yeah.
I'll start with you.
I really, really enjoyed that. And I want to give a shout out. Could folks mute if they're not talking in the background? That was really great. And the whole point of Badger Bytes being, I want to give Manish Patankar full credit, it was his idea, is to start integrating the work that's being done in the department. And this is a fantastic example. And who doesn't like talking about sex early in the morning? Fantastic. I love it. I also want to thank Jeannie Bissell. Jeannie has supported this department for years in so many ways. Moral support for me. I'm a big fan. And just supporting the chair that Cynthie holds. It's, Jeannie, you just don't know, Jeannie, what it means to have someone like you behind the department. Thank you. Now, one final thing, the older I get, the more I realize there's just so many points of intersection. And this year, I had the opportunity to work with ACOG and AGOS on submitting an amicus brief, which I didn't even know what that was. I mean, I got to be honest with you, but it's a thing that's pushing back, in this case, on the FDA for holding mifepristone hostage during COVID in the terms of requiring physician prescription and in-person prescription. And the amicus, and it's making its way through the whole system as we speak. Many medications during COVID, the FDA gave a pass on. Okay, you don't need to see a doctor, just go ahead and pick it up at the pharmacy. And of course, delaying abortion, which this whole COVID thing hasn't helped with, has been a problem. So this amicus brief was backed by most of the organizations in OBGYN and led by ACOG, which is, ACOG tends to be a little apolitical. And I bring this up because I love the work that Eliza is doing with this. I love this work in general. I love our family planning division. And I have to tell you, I'm interviewing two fantastic candidates for family planning trained, fellowship trained individuals next week. So this is not a question, but more of a shout out to the panel and a big thank you. This is at the crux of all we do. Thanks very much. Questions?
One question I have sort of for all three of you. I'm just thinking about how we can be coercive without realizing that we're being conversive, and even just by prioritizing the things that we in our medical frame of reference perceive as important, as opposed to, like, I've never talked to a woman about the impact of her contraceptive method on her sexual health. And so I'm wondering what types of collaborations we might have to implement interventions to sort of train those of us who deal in contraception to incorporate some of the findings that Dr. Senderowicz and Dr. Higgins are elucidating into our practice. I don't know if either of you guys have thoughts about how we should be moving forward with that.
Leigh, I'd love to hear your thoughts.
Yeah, thank you so much for the question. I think even just thinking about coercion as a spectrum rather than a binary outcome is really a huge step forward. It's not like, am I forcing or am I not? But what are the subtle ways that I might be coercing? And if I had had more time, one of the things that I would have loved to share more about is my finding that often coercion is not, or almost never is coercion the result of ill intent or malice on the part of the provider. I think most of us just get up in the morning, go to work, and try to do our best every day. But there are structures in place that tend to promote coercion or incentivize coercion. And so the example globally is these large contraceptive uptake targets that are set by big development organizations like the Gates Foundation, which, for example, set a global target of adding 120 million new users of contraception worldwide. And then that target is broken down by country, and then by region, and then by district, and then by clinic. And at the end of the day, providers feel like they're trying to meet these sort of quotas. And here in the US, I don't think it works quite that directly, but I do feel like the role of measurement is really important. What are we measuring? What are we tracking? How do we know if we're doing a good job? What do our bosses or supervisors or the federal government or whomever, what are they tracking to see that we're doing well at family planning? And so actually, if you'll all be attending the Women's Health Symposium in October, I'll be talking about my work on the concept and measurement of contraceptive autonomy. And I'm trying to develop a new quantitative indicator of contraceptive autonomy that we can measure quite easily, hopefully, and track our progress toward meeting contraceptive autonomy targets as opposed to contraceptive uptake targets.
Dr. Rice would like to make another comment, and then we have several really interesting questions. And I think we can go a few minutes over time. So
yeah, since I'm in charge of the department meeting, we'll go to 8:05. What the heck? Listen, I like to space out my shout outs, and I want to give another one now. This department is so lucky because this issue of contraception, don't even talk about abortion, just contraception is controversial, as witnessed by Cynthia's statements about Title X and President Trump. I think that Dennis Christensen is a warrior. And again, for me, he has been so mission critical in just pushing forward because we all feel it. I'm not alone. We all feel the force of adversity. And Dennis's support for the endowed chair, his constant appearance at M&M and Grand Rounds. Every morning, every Thursday morning, he goes, Laurel, how are you? Dennis, I am just a huge fan, and we're so lucky to have you in this department. Thank you. So 3 more minutes, Heidi.
Okay. So I think, so one question I'm going to just summarize the 3 questions that are in the chats right now. One question is for Dr. Wautlet from Dr. Patankar. With your Title X related work, would it be possible to collect data that could be used for research projects? Assuming we had IRB approval, of course, that we could potentially link data to our department tissue and data bank. And then also for Dr. Senderowicz, are you doing any research about contraceptive coercion locally? There certainly are some local sentiments that Certain groups may feel their counseling is coercive as it relates to postpartum choices and breastfeeding. And then for Dr. Higgins, does contraception improve sexual satisfaction because it decreases fear of pregnancy? So 3 very different questions. So why don't we start with you, Dr. Wautlet?
Sure. I think the answer to Dr. Patankar's question is maybe. At the state level, we're not collecting any individual level patient data. We're collecting aggregate summary de-identified data from different clinic sites around the state. I think that could lend itself very well to IRB approval and epidemiologic studies, but I don't think in the way that the data is currently collected that it would be amenable to linking to a tissue database like a one-to-one link or anything like that, other than for maybe correlational purposes.
Dr. Senderowicz, can you speak to any research you're doing about coercion locally?
Sure. Right now, I'm not doing anything locally, but I'd love to start. So if this is research that any of you would be interested in pursuing, please get in touch and I'd love to discuss that.
And Dr. Higgins.
Yeah, and Ellen, it's a great insight and absolutely a lot of my qualitative work shows that this sort of disinhibition, you're really protected against pregnancy. You can let go more and enjoy sex. And we suspect that's one of the reasons why IUDs and implants are actually showing some of the most positive sexual effects in our study because they're so effective and they allow for so much disinhibition. So you're right on. We think that's one of the pathways through which this comes about.
And I just wanted to mention too that there are some really good comprehensive contraceptive counseling workshops that providers can attend already. Some are provided, through Planned Parenthood locally, and we have had expert speakers come, like for instance, last year to the Wisconsin Contraceptive Care Summit, and that was one of the sessions that received the most positive feedback from participants. Was the session on non-coercive and inclusive contraceptive counseling. But that said, there's still a long way to go to really understand how to best counsel people in ways that make sense for them, because I think most of us as medical providers are counseling people based on effectiveness of the method at preventing pregnancy. And I think as we're all learning slowly but surely, that's often not the most important thing to our clients. So how do we reframe the counseling in a way that meets people where they're at? I think is going to be a huge benefit for patients.
This.
Okay.
Can you guys hear me? Sorry, there's noise here. I just want to shout out to the department. Leigh Senderowicz is one of our amazing postdocs in the Health Disparities Research Scholars Program that's supported by the NIH. But the NIH doesn't really provide enough support for our scholars to really get their research up and going and to present at meetings. So I just want people to see that when we make a small investment in this program, we really produce powerful investigators. They're going to have a big impact on the world. So I want to thank the department for their continued support.
Thank you very much, everyone. This has been an exceptionally fun Badger Bites. I feel energized by hearing what's happening in the department. I just want to read, Jeannie Bissell made a shout out to Dr. Christensen. He championed abortion care in Wisconsin for the last 30 years, and Planned Parenthood of Wisconsin could not have survived without you. I don't know if everybody's reading the chat bar, so I just wanted to verbalize that. And I've been strictly instructed to wrap up by Dr. Rice, so I'm not going to accept any more comments. Thank you all, and looking forward to seeing you in the department meeting.
5-minute break, you guys. 5 minutes. Thank you.